So I want to thank the organizers for inviting me. I'm going to talk to you this morning about the future of transcatheter mitral valve therapy. Before we get started, I just wanted to ask the audience to do me a little favor and just participate in a little question for me. So I want you to just imagine yourself. I want you to close your eyes and think about what was probably one of the most important moments of your life. So maybe think about when you got married, your child's graduation. Think of an event in which, what you consider to be a very important day of your life. Think about how you were on that day. Think about the day as much detail as you can. And then I want you to ask yourself, what were you wearing on that particular day? And you're gonna see at the end of this talk why I'm asking you that question, and I think you're gonna understand at the end, why is this person asking us about that? She's here to talk about mitral valve therapy, and I think you're gonna start to understand a little bit about why that might be important. So these are my disclosures. I am a consultant for Abbott Vascular. So if you think about that day in your mind, what were you wearing? There's not one thing that fits everyone, and on the most important day of our life, we wanna look the best we can. So one size certainly does not fit all. You can look at this picture. And so if you had to choose what you were gonna wear on that day, would you choose this or would you choose this? I'm not wearing either, but I would choose the other. And so one size does not fit all. We really want a solution. We want something that's tailored to us. So if you look around the room, 1 in 10 of us, when we reach 75, are going to have moderate to severe mitral regurgitation. It's a significant number of those of us in the room that are going to have either moderate or severe MR. And mitral regurgitation is a spectrum of disease, and Dr. Malte showed some beautiful images of some nice degenerative mitral regurgitation. You can see it's all very different. And when we talk about mitral regurgitation, we can talk about either degenerative or functional. There's classifications for this, but it's a spectrum of disease. If we talk about degenerative, these pictures are not moving pictures, but you get a sense that degenerative mitral regurgitation can be anything from mitral valve prolapse, myxomatous mitral valve disease, or even mitral annular calcification. So it's a diverse spectrum of disease. And this is just some echo examples of what this looks like. So here what you see is a flail of the P2 segment. So this is a disease that requires a specific therapy. If we look at the type of therapy that's used, in the majority of cases, it's mitral valve repair for degenerative MR, lower complications, lower mortality. In the majority of cases, that's what patients are getting. If you look at this publication from earlier this year in Circulation, this is 20-year results of patients treated with a flail, a segment of the mitral valve, so degenerative MR. It's a multinational registry of patients, and they follow them for 20 years. And you can see that repair results over time better survival than replacement. But what about functional MR? So that's a different kind of cohort of patients. And in this example, what you see is a patient who's had an inferior posterior wall infarction, who's got a tethered posterior leaflet and very eccentric MR. But the spectrum of functional MR also extends to those patients who have LV dysfunction. And this is a patient who's got severe dilated cardiomyopathy, who has displacement of the papillary muscles and real leaking of the valve in the center of the valve. And how do we treat these patients? Well, what's the implication of functional MR? Well, to be honest, it's very bad. If you have severe MR, you have a higher risk of either dying or being hospitalized for heart failure. And that's irrespective of the cause of your LV dysfunction. Unfortunately, how you're going to be treated is very dependent on local practice, your comorbidities, and again, the type of mitral regurgitation you have. So this is data from the Cleveland Clinic that shows that if you have functional MR, you're more likely to be treated medically. And unfortunately, if you're treated medically, your rate of mortality at 1 year is 20%. Your rate of mortality at 5 years is 50%, and almost all of these patients are going to be hospitalized by 5 years. So there's an unmet need for these types of patients who either have high-risk degenerative MR or have functional MR. And this is where transcatheter mitral valve therapy comes into the mix. If we look at the mitral valve and we try to understand what are the targets, how can we, by transcatheter techniques, actually treat the mitral valve, we can attack the mitral valve leaflets. There are techniques to do an annuloplasty. There are chordal implants that can be performed robotically. And then there's mitral valve replacement. So if we go back to that one-size-fits-all analogy, I'm not sure that one size fits all for the treatment of mitral valve disease. So this is the concept of what I think is the future of transcatheter mitral valve therapy, which is really tailoring therapy to patients. And to do that, we need to understand what is the pathology or the mechanism that's resulting in the mitral regurgitation. And we then need to identify what are the potential therapeutic approaches or even combination of approaches that we can use to address the care for the individual patient that we're seeing. So we'll talk about a couple of different therapies, leaflet repair with the MitraClip that you're all aware of, some newer annular approaches. I'm going to talk a little bit about the Cardioband, and I'm going to give you one example of transcatheter mitral valve replacement. So MitraClip is not a new device. You're well aware of it. It's been used in clinical use for almost 10 years now. It's a clip that's positioned on the mitral leaflets. It performs transcatheter mitral leaflet repair. And in terms of anatomic criteria, when we can use this is the commonly referred to Everest criteria, which are actually not used anymore. Right now, this technology is used for both degenerative and functional MR, and the real feasibility of the procedure is determined by the procedural team. There are no real criteria except for an exclusion of a mitral valve area less than 4, in which case we may cause mitral stenosis, and so the technology is not best suited to those patients. This is the only randomized trial completed. There is another soon to be completed, which is called COAPT. And all I want to talk to you about from this trial is that the 5-year follow-up has been published, and you see that at long term there was no difference between the surgical arm or the percutaneous arm. Most importantly, therapy with the MitraClip is very safe. And the 5-year follow-up showed us that the therapy is durable to at least 5 years. Patients improve their symptoms. They all seem to improve to either functional class 1 or 2. So what do we know now about MitraClip? There's over 40,000 patients treated worldwide. We know the durability is confirmed out to at least 5 years. And this is a procedure which is exceptionally safe, even in patients in cardiogenic shock. Moving on from leaflet repair, we can talk about annular approaches. And I'm going to talk to you a little bit about the Cardioband device. This is a device now acquired by Edwards, so the Edwards Cardioband. And this is a percutaneous direct annuloplasty that's inserted via transeptal into the mitral annulus. And so there's an annuloplasty implant, and there are metal anchors that anchor the device all along the annulus of the mitral valve, and then these are cinched afterwards to result in a mitral annuloplasty. This is just an example of what this looks like. You can see on the right panel the anchors fluoroscopically visualized in the annulus, and you can see on the 3D echo you have an appearance of almost a surgical mitral annuloplasty. So I'll present some data that was given to me by Francesco Maizano that was presented a couple of weeks ago at EuroPCR, and this is the CE Mark trial of the Edwards Cardioband. It was a single-arm, multi-center, prospective trial looking at the use of this technology in patients with functional MR. So this is the age population. So this was a 61 patients, mean age of 72, predominantly male, Euroscore of 7, all pretty much functional class 3 or 4, with a mix of either ischemic or non-ischemic cardiomyopathy, dilated left ventricles, a mean left ventricular end diastolic dimension of 60, and then a smattering of comorbidities, atrial fib, COPD. The most important thing to look at is what are the major safety events at 30 days. So is this technology safe? And so in fact at 30 days there were 2 deaths. There was 1 hemorrhagic stroke and 1 patient who needed mitral operation, 1 myocardial infarction, major bleeding complications in 2, and some renal failure. But importantly, if you look at the results of this technology, what you see is a good, very durable reduction of mitral regurgitation out to 12 months in this cohort of patients. So, efficacious therapy with the percutaneous Cardioband. And at 1 year, 94% of patients had mitral regurgitation less than 2+. In terms of functional status, the patients felt better, they walked further, and their Minnesota Living with Heart Failure scores were decreased. So this is early on in its development, and in fact, this was their feasibility trial. We're still waiting for further studies to look at this, but it's very encouraging. We can see that there's a reduction in mitral regurgitation. We now are having the addition of another tool in the toolbox to treat mitral regurgitation, and it also perhaps preserves the anatomy in order to perhaps facilitate transcatheter mitral valve replacement in the future. So we'll then move on to talk a little bit about mitral valve replacement. There's a lot of excitement in this field, a lot of different companies. I've only ever put 6 devices here, but there's many, many more. And this is an area of constant research and constant work, trying to develop what is going to be the perfect mitral valve replacement. I'm going to show to you just the Tendyne valve. There's a publication that came out at the end of last year. This is a nitinol self-expanding valve that's inserted transapically, and it has an apical tether that's tethered to the ventricular apex. And this is quite a large device, about a 34 French. It's a tri-leaflet pericardial porcine valve. And so this was published at the end of last year in patients with symptomatic mitral regurgitation. And what you can see when the device is successful, you have reduction in mitral regurgitation, and you also have evidence of left ventricular remodeling. So decrease in the left ventricular size at 30-day follow-up, which is quite impressive. In terms of adverse events, no deaths out to 30 days, no stroke. There was some evidence of bleeding, and there was some dialysis or renal insufficiency. What that shows us is some early feasibility, some encouragement that transcatheter mitral valve replacement is coming along. There's been a lot of work in the space, and there's a lot of sort of differing views. Some of these procedures have been associated with high mortalities, partly because of the type of patients that are being treated, but also the techniques are quite invasive. So if we talk now a little bit about the techniques I've already showed you, what should be our transcatheter approach to mitral regurgitation? Again, going back, we need to understand what is the mechanism of mitral regurgitation. What is the therapy or combination of therapies required to treat these patients? And also we have to start thinking about safety. What is the safety profile of the treatment strategy that we're proposing? And what other considerations that we have to think about? Namely, if we're talking about transcatheter mitral valve replacement, what is the role of anticoagulation? Are these patients going to need to be anticoagulated to prevent valve thrombosis? These are all things that need to be considered when we're talking about what is the optimal therapy or tailoring therapy to the individual patient. So I'm going to propose to you perhaps what I think might be the future of transcatheter mitral valve therapy, looking at a combination of techniques to really tailor this therapy to the actual patient problem. And for now, that may include leaflet repair, which we already know is safe. We know it's suitable for prolapse, for flail, as well as for functional MR. And now perhaps the blooming possibility of having annuloplasty with or without leaflet repair, which can also be suitable for prolapse and fail, and perhaps those patients with very dilated ventricles in FMR that may require an additional annuloplasty. And then finally, we have the possibility of mitral valve replacement percutaneously for those patients with either advanced DMR or FMR, keeping in mind, however, that we may need long-term anticoagulation for these patients. So just to finish, I don't believe that one size fits all for what we wear, or even for what might be the most important day of your life when you need mitral valve repair. And so probably the future is transcatheter solutions for patient-tailored therapy of mitral regurgitation. Thank you.